I'm going to talk on vaccination in pregnancy, which sounds like something very basic or simple, to a certain extent, something which we sometimes I feel take for granted. And yet, vaccination in pregnancy could actually be responsible for major contributions to reductions both in maternal as well as neonatal mortality and morbidity. So I'll start with the overview of vaccinations in pregnancy and the path that we have taken to our current selected vaccination protocol, and then talk a little bit in general about COVID, and then focus on COVID vaccination in pregnancy, which seems to be the topic du jour, as they call it. So let me begin first by saying that because perhaps of the ubiquity of vaccination, the commonness or the banality of commonness of vaccination, we actually seem to have taken vaccination a little bit for granted. But let's not forget that vaccination actually is one of science's greatest triumphs. The only disease that has successfully been eradicated due to human efforts is in fact smallpox. And when it was announced in 1979 that smallpox has been eradicated at the World Health Assembly, it was recognized then and it is recognized now that this feat is actually one of history's greatest public health triumphs. Just consider the fact that diseases which used to cause such major morbidity and mortality, and there are 12 childhood diseases like this, are now all preventable by vaccination, starting from varicella, mumps, tetanus, right down to hepatitis A and B and Haemophilus influenza type B. And that is why, as I said, vaccination seems to be something that, although we take it for granted, is still actually one of science and public health's greatest triumphs. But why should obstetricians and gynecologists bother about vaccination? Vaccination has traditionally been supposed to be the territory of pediatricians. There are some self-evident reasons why obstetricians and gynecologists should be talking about vaccines. It is an opportunity to protect women by building up active immunity, as well as neonates and infants by the transfer of passive immunity. I've always maintained that obstetrics is a very unique field of medicine. We tend to get quite close to our obstetric patients, and our obstetric patients in turn reciprocate a lot of times by listening to our advice very well. So you're looking at a receptive population who are already in the healthcare system. And the fact is, acceptance is high when obstetricians and gynecologists recommend vaccines. So this is indeed an opportunity for us not only to vaccinate pregnant women, but also to get them apace with our universal immunization program. Perhaps the first vaccines that were given in pregnancy were 2 doses of tetanus toxoid from the second trimester, 28 days apart. The logic of using tetanus toxoid in pregnancy was that natural disasters and war increase the risk of tetanus, and even though tetanus is relatively rare, because these events are relatively rare, when it does occur, it is lethal. The vaccine for tetanus is safe, effective, and economical and causes huge reductions in tetanus-related mortality. That led to us adopting the National Immunization Schedule for infants, children, and pregnant women, where early in pregnancy, 1 dose of TT used to be given, a second dose 4 weeks later, and if the patient got pregnant again, and if she had received 2 TT doses in a pregnancy within the last 3 years, then we used to give only 1 dose of tetanus toxoid. So this was considered to be the state of art for vaccination in pregnancy once upon a time. But then we know that we have got so many new vaccines which have come in. I like to call it the alphabet soup: TD, Tdap, DT, WP, AP, and so on and so forth. And it would be helpful to understand what this alphabet soup is. Bacterial diseases are grouped together. So you have tetanus, diphtheria, and pertussis. The terminology, capital or small, is based on the quantity or the dose, and whether it is WP or AP depends on whether the vaccine is whole or acellular. So for children, it would be a DT whole pertussis or DT acellular pertussis, which is more commonly known as painless injection, and DT. And for adults, it is TD and Tdap. How did diphtheria come into the picture? It came into the picture because there was actually a misconception that diphtheria is only a disease of infants and children. In fact, since the last 2 decades, India has seen 4 major outbreaks of diphtheria with an annual mortality of excess of 3,000. In the 2016 outbreak, 79% of cases actually were in more than the 10 years age group. It is therefore, if you look at this data, quite evident that a booster of diphtheria is certainly needed for adults. And with this realization came the end of the tetanus toxoid era, where TT vaccine was replaced with the TD vaccine in the universal immunization protocol to limit the waning immunity against diphtheria in older age groups. Pertussis was also something where there was a realization that infant immunization for pertussis is not protective until 4 months of life. But even within those 4 months of life, infants can get infected with pertussis and have serious morbidity and mortality in that time, so much so that more than 75% of all deaths from pertussis occurred at the age of less than 3 months. About 25% of infected infants got pneumonia or encephalopathy. And most importantly, all of this can be prevented by vaccinating the mother, who will then pass on the passive immunity to the infant. And that resulted in the global recommendations on Tdap, where it was proposed that Tdap should be administered during pregnancy in order to protect the infant in those first 4 months, when giving a pertussis vaccine to the infant will not protect, and where the majority of the mortality from pertussis occurs. Influenza vaccine also, of course, now all of us, and sometimes even non-doctors, know more about the influenza vaccine than doctors. Influenza in pregnancy was also a problem. It was recommended that the flu vaccine, but inactivated flu vaccine, is given as a single dose, particularly in epidemics. It's important to remember that the flu virus changes the strain every year, and therefore an annual shot of the flu vaccine is required. But in pregnancy, pregnant women are more susceptible to influenza. The likelihood of ARDS due to flu in pregnancy is higher. And moreover, because of passive immunity, giving an influenza vaccine to the mother confers protection to the newborn, who are not supposed to receive the vaccine till the first 6 months of life. So all this taken together has resulted in the so-called modern protocol of vaccination in pregnancy, where a dose of TD is to be given between 12 to 16 weeks, influenza between 20 to 24 weeks, and a Tdap dose between 28 to 32 weeks. But despite the seeming simplicity of this protocol and giving vaccines in pregnancy, there are still a lot of questions which patients will ask you. What should be the duration between 2 vaccines? Ideally around 28 days or 4 weeks. Do you have to change the schedule depending on the season or the time of the year? Yes, perhaps in the flu season, you could prioritize the flu vaccine over the TD or the Tdap vaccine. For late registration, can TD or Tdap be given with the flu vaccine? The answer is yes, you can, because the principle of administering vaccines together is that you should not be administering live and attenuated vaccines together. The other vaccines can be given together. So which vaccines are contraindicated in pregnancy? The live vaccines like MMR, varicella, and BCG are contraindicated. We know the famous advice that if a patient receives a vaccine for rubella, then she should be asked not to conceive for a couple of months. And if she conceives, you need to counsel the patient about the remote theoretical risk. And remember that it's not necessarily an automatic indication for MTP. However, if you're giving any of these vaccines, particularly the rubella vaccine periconceptually, it's always a good idea to note on the paper that this patient has received this live vaccine and she has been advised to avoid pregnancy for the next 2 months or 2.5 months. There are situations where patients want to travel abroad and ask you whether the yellow fever vaccine, particularly for travel to South America and Africa, can be given in pregnancy. Well, the yellow fever vaccine is a live vaccine. It has a theoretical transmission risk, and ideally you should not give this to pregnant women, and they should be advised to either avoid or postpone trial. Sometimes you see patients who have had an animal bite, and then you are asked the question whether the rabies vaccine can be given in pregnancy. The answer is yes. You can give the rabies vaccine in pregnancy because the rabies vaccine is life-saving. Not only can you give the vaccine, you can also use the immunoglobulin for rabies in that pregnancy. Although it seems to be a very important thing, the fact remains that there are some concerns, some of them true, but most of them not true about vaccination in pregnancy. For example, if you talk about the economic burden of increasing the types of vaccine in pregnancy, you may at the first instance feel that increasing the types of vaccines will increase the economic burden. But if you look at cost effectiveness or the fact that preventing a disease is much cheaper than treating the disease, by far and large, you will realize that it's actually a reverse economic burden. By far, the most problematic or the biggest hurdle to changing vaccination protocol is a change in practice. As physicians and doctors, we are creatures of habit, and it does take a while for us to adapt to anything new. Fake news about vaccines like autism with MMR or deaths with HPV. In fact, this rumor about deaths with HPV almost has caused a stop to HPV vaccinations, even in an advanced country like Japan, is something which keeps on coming up and is something which we have to be consistent in refuting. Patients sometimes come to you and say that I want to get pregnant after some time. Which are the vaccines, doctor, that you think I should take in preparation of the pregnancy? Then you can suggest these vaccines, MMR or MR varicella. But with these vaccines, the patient must delay the pregnancy. Remember to write it down. You could give hepatitis B vaccine, in which case there is no need to delay the pregnancy, or even the HPV vaccine can be administered preconceptionally to patients to get them caught up with the universal immunization protocol. Use the postnatal period to catch up with the UIP and try and ensure that the patient has received all these vaccines in case she has not received them earlier. Having talked generally about vaccines in pregnancy, I'll move on now to COVID-19 vaccine. This has raised a lot of debate, and when the vaccine wasn't there, I always used to call it the pot of gold at the end of the COVID rainbow. A few general remarks of COVID. When COVID came in, all of us seem to forget that COVID was a very new disease. We seem to expect that we should have evidence to treat COVID or make projections on COVID in line with all the other diseases that we know of, which have been present since such a long time. But we forgot that COVID was a very young disease. And how could we have the same level of evidence for COVID that we are used to for diseases which have been there for such a long time. The problems, in part, I believe, were exacerbated with some very, very exaggerated projections. Fortunately, these projections were more of the type of that WhatsApp university kind of projections, the certificate of which you can see there. I got so tired of answering questions, even in the, even where I'm living, even where I'm working. All the non-physicians seem to know more about COVID from WhatsApp and the internet than I did from reading scientific literature. Fortunately, it seems to me that India has done relatively well with COVID. Despite a significant amount of negative press, if you look at the data that is available, you'll find that our deaths per million population, for some reason, I cannot really explain why, are quite fortunately very, very low compared to the deaths per million population which are there in even very, very advanced countries or countries with much better medical infrastructure. As I said, the reasons are up to debate. I believe that there have even been questions raised about the data. But even if you look at the data and say that this data is questionable, you probably will not be able to question the overall death rate. So India has a fairly robust system of recording births and deaths. And the overall death rate of the country has really not been shown to be much different in the COVID year as compared to the year before that. It therefore stands to reason that this data seems to be more or less accurate. We know that pandemics typically occur in 3 waves. We are seeing the third wave, fortunately a mild one with Omicron, and I hope that this signals the end of the pandemic as we know it. Of course, we have one more very important weapon in our armamentarium for COVID, which was not there in the last influenza pandemic of 1918, which is vaccination. And what has really helped develop these vaccinations at a rapid rate is the research that has gone in previously, albeit unsuccessfully, for the development of the HIV vaccine. As I said, sometimes in a pandemic, you have to consider that you are not going to get the kind of robust data that you're used to. So this is Albert Sabin when he invented the polio vaccine. And this was the research that he did before starting everybody on polio inoculations. He said, I've studied the effect of our new lots of polio vaccine in 100 adult volunteers, and they have been pretty good. And so in the next few days, I'll be giving it to my wife, my 2 children, neighbors, and their children. Of course, things have changed since then. And typically, and consider this, this is really very important because I believe that this will be the most long-standing legacy of the COVID pandemic. Typically, it used to take 15 years to get a vaccine to market. 15 years. The COVID vaccine has come to market in less than 15 months. It's hardly been a year since COVID started, and the COVID vaccine started undergoing rigorous trials. For me, this is going to be the single most important legacy of COVID. The ability to bring out vaccines rapidly as a response to infectious diseases in the future and bring them even more rapidly to market is going to be perhaps the defining legacy of the COVID infection. There were some questions, particularly about Covishield and Covaxin, when they started coming into the market. And therefore, at that time, experimental use, emergency experimental use was granted. But I'm delighted to share, and this is a screenshot from the 27th of January, just 3-4 days back from our Honorable Health Minister, that the permission for both Covaxin and Covishield, after looking at the data, has been upgraded from a restricted use to normal new drug permission with certain very basic conditions of pharmacovigilance which would be there anyway. There were, of course, concerns that because the journey of a vaccine is very complex, even if you got the vaccine to market, how would we be able to deliver it globally to the entire massive population of the world? And it was therefore such a pleasant surprise to realize that the world had adapted to vaccination very rapidly. And I quite like this one sentence: when the first billion doses of vaccine were given, 1 billion syringes, a billion alcohol soaked cotton balls jabbed to the skin and tiny bandages, and most importantly, 1 billion exhalations of relief. Even in this early data, what was most striking was the fact that the period to administer 100 million doses kept on coming down in terms of number of days. There was, despite the fact that India seemed to be having the ability to stockpile as the fifth largest stockpile of vaccines in the world, some doubt on India's ability to deliver vaccinations. I, to be perfectly honest, always thought that once India gets the vaccine, we will deliver it in the most efficient way in the world, because India is a champion at vaccination. And you can see that in the graph over here. When India started giving the vaccines, you can see the India worm in green over there. It started off a little slow, but after some time, it has picked up pace. And India is by far now the country which has administered the largest number of doses of COVID vaccine. And I think that is the one metric that you need to see when you're comparing country to country. If you look at the number of people vaccinated as percentage of population, vaccines administered per 100 population, and so on, well, obviously our population is so large that we are not going to look as nice as we look in this graph over here. But the fact remains that India has done exceedingly well in vaccination. If you read that, a year after India commenced the vaccination program, we have given 1.5 billion doses. In comparison, the US has administered 520 million doses, and the UK has administered 130.7 million doses. And at present, India's 95% of eligible population is inoculated with the first dose of COVID-19. It is a magnificent scientific, technological, and logistic achievement. Like all of you here, I also took my COVID vaccine, and I also took a selfie when I took the COVID vaccine, because of this WhatsApp meme which said that the COVID vaccine won't act if you don't take a selfie while taking the COVID vaccine. I was, of course, very happy to be involved in Foxy's effort to ensure that the COVID vaccine reached pregnant and lactating women also. I must make a special mention of Dr. Parikshit Tank and Dr. Atul Ganatra, who helped Dr. Alpesh Gandhi and all of us to put this absolutely wonderful Foxy position statement together. And what the statement essentially said and relied on was the fact that in pregnancy, there could be concerns regarding transmission of the infection to the fetus only if a woman was vaccinated with a live attenuated vaccine. In India, both the vaccines that are available are not live attenuated vaccine, and therefore there is no question of our vaccines infecting the fetus with COVID-19. We also looked at several references from world over. And it was quite amusing, I think, at times to look at the people who were a little cynical about the COVID-19 vaccine. It was like that meme from WhatsApp over there. When the vaccine was not there, everybody was screaming, "Give us the vaccine, give us the vaccine." And finally, when the vaccine came and people said the vaccine is ready, they said, "Oh, that is too fast. How can we trust the vaccine?" But the fact is that the COVID vaccine has been accepted very well. This is the letter that we wrote with signatures from Dr. Alpesh Gandhi and myself to the ministry to advocate for making the COVID-19 vaccine available. I must say here, Dr. Pratima Mittal is there, Dr. Neerja was there in that board, and everybody was very helpful when it came to advocating for the use of the vaccine. And finally, the COVID vaccine was allowed first in lactating mothers, then in pregnant mothers. Again, there was some confusion on social media, but I do hope that now the confusion is very clear. There is enough data now to show, starting from this article, which was published in very recently in 2021, and now this article, which has been published on the 4th of January 2022, just 20 days back on the CDC website, where in a cohort of more than 40,000 pregnant women, COVID-19 vaccination was not really associated with any sort of increased side effects. In fact, I think it would be safe to say that COVID-19 vaccine should be added as a standard of care to all the other vaccines, TD, Tdap, and Influvac that we talk about. And we have started to give COVID-19 vaccine routinely, both doses to the patients who have not been immunized so far with the COVID-19 vaccine. So as I said, we need to reflect on the legacy of this pandemic that we have lived through. And in the rush to get back to normal, let us use this time to decide which parts of normal are worth rushing back to. I would strongly feel that one of the enduring legacies of the COVID pandemic is in fact going to be this ability to manufacture and bring vaccines for infectious disease to the market quickly. So as far as maternal immunization is concerned, where are we now and how do we move forward? I have already said that pregnancy and the postpartum period are in fact elevated with risk to both mother and infant. Vaccination has the potential to protect not only pregnant women, but fetuses and infants from several vaccine preventable disease. And years of experience suggest that maternal immunization against influenza, tetanus, and pertussis not only has an acceptable safety profile, is well tolerated, but also confers significant benefit to pregnant women and their infants. And we add COVID-19 vaccine to this list. So let me end by this quotation which says, pathogens are mindless and relentless, but science is relentless too. If there is anything the pandemic has taught us, it is this. Let me end by requesting everyone here to please support me as I stand for the presidency of FOGSI. I've got a website, it's called isupportjaydeeptang.com. If you're watching this on your laptop, you could scan the QR code on that other side. It will take you to the website. Once you're on the website, you can register your support for me, and I'm absolutely honored and thrilled to share that literally thousands of Foxians have already registered their support for me. I have a video blog section on the website where a whole lot of my previous presentations are there, or you could, of course, elect to follow the Telegram channel where I put up whenever I'm speaking in a webinar, including this one. Thank you very much again.